Great. All right. Well, thank you for the invitation to do this presentation on suicide prevention and integrated care. I guess I'll start by giving a little bit of background of myself. I'm a licensed clinical social worker in Missouri, and I'm also a PhD student in the medical family therapy program at St. Louis University. So I guess as far as my interest in suicide prevention, that's what my dissertation topic will be on. So I've been studying this area for about 4 years now. So hopefully you all will walk away with some helpful information. And essentially, at the end of this presentation, I hope you all will be able to take away how suicide prevention and behavioral health integration can be weaved into primary care, and as well as some resources and things that you all can take to patients or clients and things like that. So, um, why is this an important issue? I guess a little bit more background information. While I was out in the field working at a local organization here in St. Louis called Chad's Coalition for Mental Health, teaching high school students signs of suicide and how to kind of report that to a trusted adult and work with students and so forth. My uncle actually died by suicide. And the latest stats that I can recall, 1 in 6 people know someone who have died by suicide. And I know it's kind of hard to see with the little boxes, and maybe this is just a question to think about um, in your mind is, if you have known someone who has struggled with suicidal ideation or an attempt, or even maybe yourself, and what kind of impact that has had. So not only does it have a personal impact on our lives, but also at you know it impacts society at large. And another example that I think is just glaring is the 13 Reasons Why Netflix series. And again, if not sure how many of you are familiar with that or have seen that show, but I had a colleague who mentioned that I should see it. And I said, yeah, I definitely should. Right before I had walked into an appointment with a teenage client. And sure enough, that client had mentioned something in reference to the Netflix series in session right after that. So not only did that have an impact on me and my clinical work as well, but also research is catching up with the impact of suicide in media. And here's an example of how excuse me, I'm getting over the flu, so I apologize. But a JAMA article came out May 29th showing that there were increased hotline calls to the suicide prevention lifeline number after the release of this Netflix series. So this is definitely something that impacts everyone, really, whether you may be connected to it personally, the topic, or in working with patients and clients. And with that being said, Kate Snow has a really great 1-minute clip on how to talk about suicide in the media. So I will share that really quick because I think this is a really powerful message coming from media.
Suicide is currently the 10th leading cause of death, and the words we use to talk about it matter. That's why many people have stopped using the phrase commit suicide, and instead they say died by suicide. It may sound like a subtle distinction, but the word commit implies that a crime has been, well, committed. Even though it's complex, in most cases, suicide is the outcome of a mental health condition and other stressors, someone who's in deep distress and in need of help. Saying commit suicide assigns blame at a time when understanding and empathy are needed. Instead, say someone died by suicide or took their own life. It's a simple change we can all make that will go a long way in creating a culture that's smart about mental health and let a little bit of light in where once there was darkness.
So I think that speaks volumes to how we even just talk about the topic in general. So I hope that is helpful in moving forward and moving this discussion forward, and how we talk about the topic of suicide, because little things such as language and commit versus died by suicide can make a great difference in how we continue to break the stigma and move this topic forward. So just some basic statistics from the American Association for Suicide Prevention. As Kate just said, suicide is the 10th leading cause of death in the United States. This data is from 2017, 47,173 Americans died by suicide. And there are many more suicide attempts. And when you think about when a person dies by suicide, the financial implications are quite large, between funeral costs and time off work and things like that. So these statistics show a little bit, excuse me, about how we can better prevent this issue. Excuse me. And the national age-adjusted suicide rate in 2017 was 14 per 100,000 individuals. And men tend to die by suicide more often than women, especially white men. And the last bullet point here, which I'll explain more in a few, that firearms accounted for over half of all suicide deaths. So suffocation, about 30%, poisoning, 14%, and then firearms are half. And if any of you want to do any additional reading, in August, the NPR has a podcast and article that is quite eye-opening in regard to how health professionals regard the use of the word firearm when talking with patients, and suicidal ideation and attempt. So that is another takeaway that I hope you all will remember, is just have that conversation, which I have a bullet about that too later. So some more statistics here before I get into a little bit of background info about integrated care and risk signs and risk factors and warning signs, and then also some trainings and resources that hopefully the links work in the PowerPoint to take home and use for future reference. So suicide rates by age, again, middle-aged 45 to excuse me, that the middle-aged range, and you can also see the higher age trend in adolescence as well. And suicide rates by ethnicity, there is increasing rates of suicide among whites and American Indians. So some Missouri statistics, you can see that the red line indicates Missouri, and the blue line in the PowerPoint is the national average. So Missouri ranks higher, and we are 18th in the United States as far as suicide rank. And if you think about it, on average, one person dies by suicide every 8 hours in the state. And um, again, it's the second leading cause of death for ages 15 to 24. And in the bottom right hand, left hand corner shows some more financial statistics as far as the grade, the financial impact that suicide has. So a little background on suicide prevention. A lot of the initiatives that have been spearheaded initially came from the 2012 National Strategy for Suicide Prevention report, which recommended routine screening for primary care patients. And this is a great recommendation, but in clinical care, it's time management is a very difficult thing. And when you have a patient coming in who might not have a history of any mental health condition, time it can be a barrier. So so screening does not necessarily always take place, although it is recommended, and it is initially, or I'm sorry, it essentially depends upon the clinical setting. And the screening of suicide prevention in primary care has been shown to be effective to prevent suicide. The issue there is we, as clinicians and healthcare providers, have to ask. So there are lots of things that we can do in an integrated care setting, and lots of things that an integrated care team can do if the clinical setting is has that luxury, or is able to do that. And carrying contacts is another initiative that has been shown to help prevent suicide, and I have another slide on that here in a few. So again, the background, the Action Alliance in 2012 really spearheaded a lot. Henry Ford initiated a perfect depression care program, and then the Zero Suicide Initiative alongside the Suicide Prevention Resource Center, partnering with SAMHSA, have been great resources to create organizational structure for suicide prevention in the healthcare setting, as well as Veterans Affairs. And you can see on the right-hand side the components of Zero Suicide that I will hopefully get at in the presentation is, training of staff, whether it be gatekeeper training or advanced clinical training on specific evidence-based treatments. But ultimately that starts with the leadership at the organization. So how you identify and engage and treat patients with suicidal ideation or are at risk for perhaps another suicide attempt. How can you treat them, and transitions of care, as well as that circular quality improvement. That quality improvement piece is important, and documenting and so forth. So like I mentioned, research shows that, teaching how to educate and recognize depression is an effective way to reduce suicide rates, and primary care has become a de facto gatekeeper for some of these suicide prevention efforts, because a lot of people will present at a primary care clinic or emergency room or another healthcare setting, as opposed to a mental health clinic or so forth um, for thoughts of suicide. So on average, 45% of patients who died by suicide had contact with a primary care provider a before within 1 month before um, they had died by suicide. So I think that that piece of data indicates the great opportunity that we have in the ability to integrate behavioral health into primary care. Um, and how we integrate psychotherapy and medication and um, ultimately treat and interact with patients who identify can reduce barriers for treatment down the road and potential emergency department admissions and so forth. So ultimately, some of these barriers are healthcare system issues, because what is commonly occurs now is, if it's not necessarily an integrated care team working together, a lot of times physicians or primary care providers will refer to the emergency department, which research has shown that increases the risk for suicide. So that was a little background about the future implications for integrated care and suicide prevention. So I'll kind of dig into some of the common terms and concepts. There's there are the trainings, which there are an array of trainings. I have a couple slides that provide comprehensive lists of different options that you have the option to take to a clinical site or ultimately implement if this is something you're passionate about. Screening tools, how to do an assessment to kind of weed out, does this person have passive suicidal ideation, or do they have a plan, and do they have means to carry out that plan? Have they had a previous suicide attempt? And then if the risk is high after that assessment, what do you do from there? So I'll talk a little bit more about safety plan, looking at protective factors, and ultimately asking patients about their reasons to why they want to live and what wakes them up in the morning. And then lethal means counseling. Again, like I mentioned earlier, this is huge. A lot of people, at least what I've heard and what I've read in the literature, aren't necessarily too super comfortable talking about firearms because of political reasons or whatnot. But talking about firearms, lethal means of medication, and most importantly, how to store or safely have those lethal means away from that person if the risk is high. And then essentially the suicide care management plan. So what does that look like moving forward across time? Because oftentimes a lot of people do have thoughts of suicide, but not necessarily um, a plan to act on those thoughts of suicide. So um, what does that look like moving forward? So like I mentioned before, and I apologize for the typos in the heading, there are quite a few of trainings and screenings and assessments and interventions at ranging degrees of empirical support, but a lot of resources to use with what you are comfortable with or what the organization you might be working in or provider would prefer. So um, some of the, excuse me, some of the common risk factors, previous suicide attempt, like I mentioned before, especially within the last 3 months, and or even next bullet, at a higher risk if there's a recent discharge from a mental health facility or an emergency department or an inpatient admission for a psychiatric, inpatient psychiatric admission. If there are mental health diagnoses, substance abuse, alcohol abuse, trauma, unstable finances, housing instability, lack of healthcare access, relationship loss, perceived loneliness. They express isolation, shame, hopelessness, increased impulsivity or aggression, and again, back to firearms if they have easy access and to lethal means or firearms. Those are definitely significant risk factors. And veterans, American Indians, and LGBTQ populations are also at higher risk. Some warning signs are perceived burdensomeness, they withdraw or isolate, increased alcohol drug use. If there's passive talk about just wanting to die or looking for a way to die, that is oftentimes a good opportunity to engage in a conversation. If someone is feeling trapped or in unbearable pain and expressing no interest to live, that's also another good time to have that conversation. Giving away valued possessions is another significant warning sign, as well as rapid mood changes, because it's shown that if people with a plan and a plan to execute, there is a sense of calm and peacefulness that will come before that either suicide attempt or um, potential suicide, because that person will know that it's a way to make that pain stop. So when you talk about suicide, um, you know, being direct and empathic and showing availability to communicate attentively, even during those times when it may be in a rush from patient to patient or trying to get through the clinical flow. A lot of patients want to just be heard and felt understood. So we encourage, to talk openly and matter-of-factly about suicide, because contrary to what, some myths that are out there, is if you talk about it, you could encourage an attempt, but that's not the case. And using open-ended questions and avoid leading or speaking for the patient can also help them feel heard when you're talking about suicide, and providing support, and especially normalizing and validating their feelings, even if you might not understand the place they are coming from. Sometimes they just don't have anyone to talk to or express these feelings to. And oftentimes, when a person is in such a vulnerable state, it's uh, great to encourage a close family member or friend to join in as a source of support. And um, obviously, just trying to instill hope and genuine care when someone is expressing that they are in such great pain. So some training options here, like the slide before. These two links here have an array of online resources for training, like I said, ranging from gatekeeper training to, let's say, in a clinical setting, front office staff who might be answering telephone calls of people who are in distress. There are a range of trainings, as well as, like I mentioned earlier, trainings for high school students and kids on how to help their peers, and who to go and where to go and who to talk to um, in in situations of distress. So SAMHSA is a wonderful resource, and I'm not sure how many of you can see. I should have posted this one on the slide too, but there are little cards like this. This is a inside of the photo, or the clip on the left-hand side is on the inside, and the Is Path Warm is also one of the other interventions that I mentioned on that rectangular slide, or rectangular box with the list of various interventions that are as simplistic as the Is Path Warm, just little reminders when you're in a room with someone. And at the bottom, there's a SAMHSA link that you can click to place an order of these, and the little green cards with the suicide prevention hotline number. I believe I have a clip on another slide. You can also order those from SAMHSA for free. So I have made multiple orders and have handed those out quite frequently to patients, and they are a wonderful resource, not only for patients themselves, but family members and other clinicians, and just to kind of, lay around the clinic or wherever you might be practicing or working with patients who might be at risk or might not necessarily even want to talk about it. It's just another resource in that regard. So SAMHSA is a wonderful, wonderful resource. So onto screening. PHQ-9 is, or PHQ-2 are the most common. The Columbia Suicide Severity Rating Scale, or CSSRS, is also another common screening tool. It's a little more comprehensive, which you can click the link there to see what that tool looks like and how to implement that. And essentially, those tools are used. The screening tools are used to assess risk. So if someone is at at low risk. Obviously, follow up, documenting that, and checking in is a great thing to do. The Lifeline number with the little logo there in the middle, those are also an option of cards and resources that you are able to order for free from SAMHSA. Um, if someone is showing, more moderate risk, then that's when you might want to implement a safety plan, talk about, how to get rid of any or safely store any lethal doses of medications, and then have that firearm discussion. I know that can be kind of a touchy topic, and that's where family and friends can come into play, especially especially in clinical practice. I've had conversations with older males saying, hey, is there a friend who you can reach out to and say, can you hold my firearm just for, an extended or, a period of time while I'm working through what I'm working through, to have that mean be not easily available. And going back to integrated care, if that is an option, a team consult is great to get. If the provider has been working with that patient for a while, to get previous history, aside from what the patient might divulge, and then exploring what possible treatment referrals from there, from an outpatient basis, might be beneficial. And if they are, if the patient is expressing high risk, range, emergent care, and ensure continuity among the transitions of care. And that is a huge piece, because oftentimes when people are discharged from either an emergency department or inpatient admission for psychiatric concern or suicidal ideation, the follow-up piece in that window of time is definitely a vulnerable time. So intervention is especially important then. And I'm not sure how legible this is. This is a resource from SAMHSA that outlines a little bit more about what to do in kind of a flow chart manner, from low risk, moderate risk to high risk, and what to do in that regard. But I think the main takeaway here is the two bottom boxes that go across any risk level. Encourage social support, family, friends, and if the patient has a therapist, consult, and have that continuity of care, and documentation. So this is another great resource by SAMHSA. And the middle box shared between the moderate and low risk, evaluate for psychiatric disorders, other stressors, and some of the risk factors and warning signs that I have mentioned previously. So, and the safety plan, I'm kind of curious if there are any individuals who have done safety plans or have seen the safety plans with patients. But I think the biggest takeaway is maybe some of the top three takeaways are, the people and settings that they can go to, and the people they can ask for help, and some of those protective factors, and also what are their internal coping strategies, and that might be an opportunity to explore further behavioral health or counseling referrals. And then I guess up to the top warning signs, what does this individual notice, or what are some particular triggers that indicate that a crisis might be looming. And then also with the patient safety plan, it's great to not only write on this safety plan, which I've made copies for and scanned into the medical record, providing the suicide prevention lifeline number with this safety plan, so they can take this home and pull this out in a moment of crisis and look at what different clinicians they have access to, and who they can call both during business hours and after hours. And then kind of closing it up, what can they do to make the environment safe, and what is important to that patient that makes them want to live. So exploring all of those things with a patient who is at high risk for suicide, definitely important to do. So some of the treatments, and this is a resource from AFSP, American Foundation for Suicide Prevention, is some of the evidence-based interventions, the caring contacts, and some of the CBT, cognitive behavioral therapy for suicide prevention, DBT, and CAMS, collaborative assessment and management of suicidality. Those are all evidence-based interventions, but are lean a little bit towards more of a therapy, counseling kind of orientation, where those interventions might be more fit for a referral. And even better yet, if those are all co-located, or integrated with the primary care facility, that is a great way to ensure that continuity of care throughout these struggles. And safety planning and reducing access to lethal means, those have obviously been shown to reduce suicide. And the least restrictive care is also important, given that patients are at higher risk for suicide after being in a restrictive environment, say an inpatient psychiatric hospitalization or treatment. So providing, obviously, like I mentioned, the crisis hotline, and then whatever kind of brief intervention. And if there aren't, psychotherapists or a psychiatrist on site, what brief interventions, if there's a behavioral health specialist or social worker or even community health worker. And, next, if the risk is high, emergency, respite, hospitalization, or, inpatient psychiatric hospitalization is a good way to go there to ensure that the patient is safe. And it's really exciting to see the mobile crisis teams and telemental health initiatives being more so implemented around the state, and around the country. So a lot of great avenues to get in touch and stay in contact with these with vulnerable populations. So here is an example that I pulled from the Zero Suicide website about a caring contact follow-up, which is simply just a postcard. And I'm on the Zero Suicide listserv, and there's been some discussion about confidentiality. And so I've heard of people putting, organizations putting something similar into an envelope to preserve that patient confidentiality, but essentially just a handwritten or postcard note that tells a patient that you're thinking of them as, you know, a clinician or a group of clinicians, and that you're there to reach out to as a source of support. And lastly, quality improvement and documentation are important when talking about suicide. You know, organizationally looking at if a patient dies by suicide, how did that, what led to that? What were some gaps? What could potentially be improved? And SAMHSA and the American Association of Suicidality has resources for postvention. So if an organization or practice experiences a patient who dies by suicide, or even for family members, what does that look like after, and what are some resources to cope and heal from that grief and distress of that loss, both, you know, individually and organizationally. So and then documentation, this piece is really important. How to note that a patient might be at higher risk and indicate follow-up and when to rescreen, whether it be at each visit or, you know, like I said, depending on risk, 3 months down the road, what does that look like? And it looks different for every organization or practice, but the importance of screening and being able to monitor that risk and that level of risk, and some of those protective factors or coping skills that an individual may be using are important to document. So lastly, self-care is huge. There is an alarming number of physicians and healthcare providers who are dying by suicide. So having that awareness of personal emotional reactions is essential to being a healthcare provider working with a range of vulnerable populations. So being able to connect with colleagues and talk about experiences, and you know, definitely maintaining that work life balance is huge, to not be able to take that home with you. And excuse me, and I think this quote on the right hand side speaks volumes. You know, an empty lantern provides no light. Self-care is a fuel that allows your light to shine brightly. So, you know, as we continue to work with vulnerable populations and understanding how we deal with that as clinicians, and those in the field, is very important, because it has an impact on how we communicate and seek to understand what patients who are experiencing suicidal ideation or a previous attempt are going through, because I can't say how many safety plans I've filled out with people having very little social support, if any at all, outside of an institutionalized healthcare setting. So, so that bears some weight on healthcare professionals. So, lastly, here, I know in St. Louis, the suicide prevention lifelines will dispatch to a local a local behavioral health crisis response team, and that's another resource, I guess, in the St. Louis area. But SAMHSA, the Suicide Prevention Resource Center, American Association of Suicidology, AFSP, American Foundation for Suicide Prevention, and the Zero Suicide initiative has a wealth of resources to be able to use, not just with patients, but to also take back to leadership. And if say screening is done as frequently, or if screening maybe should have been done when there were some risk factors and it wasn't, these are some great resources to utilize to try to get leadership on board, as hard as that might be with the time restrictions and so forth, as I know exist in the healthcare system. So I guess with that, are there any questions, comments? Marcy, did there happen to be anything pop up in the chat box?
Nope, it's been quiet.
Okay. Okay. Was this helpful? I see some heads nodding in one. Okay, that's helpful. Is there a way to see how many people have had similar experiences working with patients with suicidal ideation, or kind of how to triage and deal with, transitions of care and so forth?
Looks like Springfield has a couple.
Have one at
maybe.
Southwest.
Is there any studies that look into comorbidities and higher rates of suicide, like that in heart disease or COPD have higher instances?
I know definitely with cancer, and I think that explains the higher age, why on that slide with the age breakdown of suicide rates, why they're older populations, but definitely mental health diagnoses and chronic pain. And there's kind of been a spike in the overlap between chronic pain and opioids and the opioid epidemic. I've read some literature lately because part of my role as a research assistant, I do a lot of work with opioids. And if physicians initiate that conversation about tapering or reducing the dosage of an opioid for chronic pain, that has sometimes been shown to lead to suicide. But a lot of chronic pain conditions, because you also see that almost ambiguous loss of what maybe someone had been able to do previously, or the quality of life that they may have had before, and that has changed. And so that transition is often accompanied by hopelessness and despair, and lack of future planning, and so forth. But definitely mental health diagnoses. And one of the statistics, I don't know if I included that on here, were mental health diagnoses, because a lot of patients who die by suicide are shown to not, and I cannot recall the exact statistic off of the top of my head. I want to say it's in between like 60 or 70%, do not have a mental health diagnosis. So there are a lot of obviously mental health comorbidities, but also physical health comorbidities when there's a traumatic kind of shift in functioning.
Thank you.
Any other questions, comments?
And one thing I would like to add too, I know this was in a slide, I don't know if you can see it, it was up here, the safety resource. I don't know if I mentioned this. This is another great resource that you can also order from SAMHSA for free online. And it's the safety stands for, it's right there, suicide assessment, 5-step evaluation and triage. And it's just a nice little laminated pocket resource here. I'm not sure if you all can see this little box in the corner here, but when you open it up, it mentions a lot of the risk factors that I just mentioned, a lot of the protective factors, and how to look at the ideation plan. And then it has a essentially briefer table of what I showed you from the yellow and blue and red SAMHSA resource. But I think ultimately looking at the protective factors is especially important, because a lot of times you find that nothing is going right for these patients, or that's how they perceive what's going on. And so using a strengths-based patient-centered trauma-informed approach in having that communication is very important too. And how there is essentially overlap between the physical health and mental health comorbidities with the suicidal ideation. So essentially just communicating about what helps get them up, and what's worth living for, and how to help connect them with resources to build those coping skills, and try to encourage just minute by minute, what can they do day by day to make things just a little better. So, but SAMHSA has a wealth of resources, and I hope the links work. I can't recall if I put my email on the slide, but I'm more than happy if there are any other questions or inquiries about resources, feel free to reach out.